So welcome to this series called The Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk.
This piece is presented by Monty Mython with Desiree Chappell, featuring their guest Mike Grocott, Professor of Anaesthesia and Critical Care Medicine, University of Southampton, and Tim Miller, Associate Professor of Anaesthesiology from Duke University Medical Centre. Have a listen.
So for this particular session we're concentrating on enhanced recovery through the whole pathway for this weekend. And we've got as far as concentrating on the fluid management component of it. And when we asked Henrik Kellett, when we did a special interview with him this morning, he reminded us that the original pathway only had 5, in his opinion, key elements to it. And in his opinion, one of the key elements is fluid management, and it's to give not too little and not too much. Now, Tim, you are an internationally recognised expert in this area, and you've spoken and written a lot about this. And quite commonly quoted is a risk-adapted matrix, which comes from an article by you, lead author by you. I saw it on a tweet yesterday, which says that the most complicated patients having the most complicated surgery should have advanced hemodynamic monitoring and a goal-directed approach. At the other end of the spectrum, there was a box that said zero balance. Now, when the article was written, we all thought that was the right approach to the less complicated patient, i.e. bring them to recovery area with a fluid balance of 0. Now, that's changed, hasn't it? Our thinking on that's changed.
It has. So the RELIEF study was published in the New England Journal of Medicine, which was a multi-centre study by Paul Miles and his group, looking at restrictive versus liberal fluid management in major abdominal surgery. And they got nice separation between the two groups. The restricted group had approximately 2.5 litres of fluid in the operating room, and a very much a zero balance approach with overall weight gain, I think it was 0.3 kilos. So they pretty much stayed at their preoperative weight. Whereas the liberal group had about 3.5 litres of fluid. They were about 1.5 kilos positive, so 1 to 2 litres positive fluid balance at the end of the case. And there was a clear difference between the two groups with regards to acute kidney injury and the need for renal replacement therapy being greater in the restrictive group. And it's a nice story in a way, because the Bellamy curve, the kind of U-shaped curve, has always suggested harm if you become too restrictive. The data, particularly from Mass General Hospital, observational data, 100,000 patients, showed that the group that got the least fluid had a higher incidence of acute kidney injury. And now we have this large randomised controlled trial in the New England Journal, again saying that the group that were restrictive had a greater incidence of acute kidney injury. So I think the message is clear that we don't want to aim for zero fluid balance in the group that don't have advanced hemodynamic monitoring. We want to aim to be 1 to 2 litres positive. And I'm publishing an article at the moment with Paul Miles, and we've changed this risk-adapted matrix for that bottom left-hand group to aim for 1 to 2 litres positive.
And I presume therefore all the other quadrants as well. It's just because traditional goal-directed fluid therapy, one of the criticisms was you landed the patient about 1.5 litres positive. If you look at the literature overall, you never landed them 0. So I presume all quadrants are 1 to 2 litres positive.
Yeah, we've put it in every quadrant. So you do goal-directed therapy in those higher-risk patients, but aiming for 1 to 2 litres positive. So even though you're using advanced hemodynamic monitoring, there's some times when you're in the grey zone, shall I give a fluid bolus, shall I not? So it's useful to have an overall goal, and if you have that overall goal of aiming for 1 to 2 litres positive, it may be that you'll perhaps err on the side of giving a fluid bolus when you're in the grey zone, whereas perhaps a year or two ago you may have erred on the side of not giving it. So a subtle shift towards being slightly more liberal with fluids.
So I'm a resident in the PACU, and a patient comes back having had goal-directed fluid therapy using advanced hemodynamic monitoring, and the fluid balance is recorded as plus 1.5 litres. The stroke volume is optimal, everything's looking perfect. Slap on the back, hurrahs all round. Yep.
Yeah.
If they come back with minimal monitoring and the fluid balance is plus 500 mils, they probably needed more or should get more fluid. Is that basically it?
Yeah, obviously it's surgery dependent, but I think as a broad rule of thumb, yes.
So if in doubt, the one that's just half a litre positive, don't feel bad about dropping them an extra litre or so if they get a little bit hypotensive or tachy or oliguric, whatever it is. But when you get to the plus 2 litres, put the brakes on and increase the thinking or increase the monitoring.
Yeah, and liberal fluid management has got very bad press. I mean, from the studies that were done 10, 15 years ago with Brandstrup, etc., that liberal fluid management causes harm. And I agree that it does. But we have to remember that the harm signal in that really liberal fluid group was when you got 3 to 6 kilos heavier. You had 3 to 6 kilos positive fluid balance. So 1 to 2 seems to be about the sweet spot.
Mike?
Well, just to pick up on that, I think the restrictive group, I mean, it's always difficult to compare these papers exactly because the time periods over which the fluids are reported are a little bit different, but my reading of Brigitte Brandstrup's original paper is that the restrictive group in that study are comparable to the liberal group in Paul's study, and actually are also comparable to both groups in several of the minimally invasive cardiac output studies that were published at a similar time, where the separation was only about 500 mils. So they're kind of about 3.5 litres positive, not balanced, but 3.5 litres administered was common to many of those studies and would fit with the more liberal group in Paul's study.
I agree, and I think in Brandstrup's original study, as you say, the restrictive group were not that restrictive. It gave it the name, which was perhaps a bad name to use, and over the years we've gradually given less and less fluid, and I think relief has just nudged us to make our fluid management.
The terminology's been a curse.
I was just going to say that. It's the worst thing that could ever happen. I know you've told the story, and I have too. We've had people come up to us and say, I have to do a restrictive approach for my goal-directed therapy, and I gave 500 cc's of fluid for the entire, a large colorectal case or whatever it is. So
perioperative fluid management is more than just that bit in the operating room. So can I take you back, Tim, to the preoperative bits? Now, everyone seems to accept the no NPO after midnight. We'll talk about how often people apply that, but it's in all the guidelines. It's in the ASA guidelines.
Yeah.
So clears to 2 hours preoperatively. Some paediatric centres have gone to no NPO for clears. There seems to be some traction for that. And there's a lot talked about the carbohydrate drink. Now, I don't want to get into the type of carbohydrate drink. We've done that in detail elsewhere. I want to talk specifically about the diabetics, which are still stressing some people. So the carbohydrate drink, for some of us it's a bottle of whatever it is the night before, a bottle the morning of. For others it's just a bottle of the morning of. What do you do at Duke and what do you do about the diabetics?
So we just give on the morning of. Yep. We don't do the night before, and we give it to everyone, with the exception of a brittle diabetic, a brittle type 1 diabetic, who are actually very, very rare. Other than that, diabetics will get the carbohydrate drink, and they do. It does raise their sugars temporarily, as it does in everyone. Yeah. But one of the advantages of the carbohydrate drink is it reduces insulin resistance post-operatively, and I think that's clear, and that's as valuable, perhaps more valuable, in type 2 diabetics who already have some insulin resistance than any other patient. So I think it's very valuable to give the drink in type 2 diabetics, even though you will have a short-term sugar rise.
But the greatest benefit is thought to be in the diabetic. What about the previously unrecognised diabetic, which there's a large tranche of them, those who get quite a big sugar bump, and that tells you that actually they are pre-diabetic? What do you do about those? The unexpected on-the-day sugar bump where someone hasn't tracked their preoperative HbA1c, or does that never happen at Duke?
No, I mean, you will get some patients that put their sugar up and keep their sugar up, and folks say, well, should we be giving the drink because their sugar has stayed up? And I do agree, that's someone who's probably an undiagnosed diabetic. Those patients are probably, and we have some data now from Tracy Secchia, endocrinologist at Duke, at higher risk than people who are known to be diabetics and treated. So I think this puts those patients into a different category, and they should be started on an insulin infusion, and they probably should have an endocrinology consult post-operatively, because they are probably an undiagnosed diabetic needing treatment.
Because when I was younger, managing diabetics with intravenous glucose and insulin was de rigueur for major surgery, people seem to have shied away to it. Now they're a bit reluctant to start the insulin. Mike?
I think it's a really interesting challenge. My impression is there are two separate groups. So there's a large group of undiagnosed diabetics in whom an HbA1c is likely to be elevated. So if you look for it, you've got a priori evidence that they are diabetic, and they seem to do actually worse than the known diabetics, because I guess we don't focus the attention on them. And then there's another group who don't fit into that category but have a stress hyperglycemia response, who also, from the limited available data, look like they have worse outcomes than the previously known diabetics. And it feels like one of those areas that if we look a bit harder, we screen a bit earlier, we can get control working with the diabetologists and potentially make quite a big difference in not the known diabetics, but the unknown and the stress hyperglycemics.
But the key message is, if you're, as we keep talking about, is if you like to starve people to make them not look diabetic, that's the worst possible way of managing the situation. Desiree?
No, I mean, completely agree. And we, practically speaking, in the facility where I was working, struggled when we first started with the carb drinks, and we would draw hemoglobin A1Cs and do all the pre-op testing, but not really manage it necessarily. What you hear a lot about is that you have the levels, but then you don't really treat them. And so whenever we started the carb drinks, we really were dealing with a lot of hyperglycemia and canceling cases if their sugars were out of whack, and having the conversation with the surgeons, and then once we kind of understood what we were dealing with and started to do a little bit tighter control of glucose for those patients with their numbers that were fluctuating quite a bit, it didn't become a problem after that. And we learned to manage kind of, we would reduce for brittle diabetics, reduce the amount of carb drink that they ended up taking, or for some of our other patients, just treat it more aggressively. So.
And Tim, in the post-operative period, we've touched earlier on today about getting Foley catheters out quickly and being more relaxed about urine output. Are you still getting the IV down as quickly as possible? What are your criteria for getting the IV down post-op?
Yeah, we will frequently get the IV down in PACU as long as the patient is drinking and taking some oral intake. I do think that perhaps relief has just nudged us a little bit more to, in some patients, keeping the IV in for overnight on that first night. 'Cause again, they had the difference in their post-operative regimes.
Yeah.
And it may be that some patients are just not going to take enough oral intake, even if they're given a bottle of water. And there's maybe no real downside to just keeping a little bit of maintenance fluid in that IV overnight.
So perhaps relaxing towards what they had, about 1.5 mils per kilo per hour?
Yeah.
Overnight, and review it in the morning?
Yeah.
Because that takes out that slight anxiety of, I know we've been trying to, one of the reasons for getting the drip down in PACU is to show to people it was possible.
Yeah.
But there is a slight buffer in there to say, well, a couple of litres overnight. What we don't want is the drive-by shootings with saline for oliguria. That's the thing we're trying to stop. Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher, or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.